I am a master level social worker. I am someone throughout the years who has specialized in geriatric clinical practice, but I'm also the owner and CEO of a small firm called Suicide Care Consulting Services. And in this firm that I do, basically what I work on, my overarching goal is to help various agencies, like various healthcare systems, eliminate the revolving door effect that is just so notoriously prominent within our systems. And one of the biggest things that is of very big concern to me is the fact that, like, say you have someone who goes inpatient, they're suicidal, and they end up going inpatient, and then they come back out and then they readmit sometimes even after a couple of days, and there's this sort of song and dance that occurs across systems, leaving patient frustrated, leaving health providers frustrated. Everybody gets frustrated across all levels. The patient looks like a frequent flyer. The patient notices how broken the system is. And this is something that is of big importance to me because a little personal disclosure, I've been in the field for 15 years now, but I myself am a suicide attempt survivor. And so for me, seeing personally just how broken the system is and even working in the system to try to help see what I can do to make hair transitions a little bit smoother, that's been something that has been a challenge that I see as I work with and speak with folk across various systems. Like, how do we come together to make sure that there are some best practices to help minimize the revolving door effect and at someday be able to eliminate it? So it is a pretty big goal that I have, but I'm working small and easy. A little bit more about my background. I have worked as a healthcare systems administrator in compliance, legal, HIPAA. I've also worked even as a crisis counselor, so I've done a lot of crisis counseling in my day. I'm also clinically trained as a suicide care specialist, using various interventions to use a suicide care framework when working with patients to help mitigate suicide care, especially when people are transitioning from an inpatient level into outpatient level. And I've spoken on this topic in various locations. I've spoken with the Midlothian Police about 45 minutes outside of Dallas, Texas, to talk about this very topic. I've also presented at the Vermont Suicide Prevention Symposium, and I've also done international talks, appearing on podcast episodes and doing various speeches about what are some of the issues that we see within healthcare systems that make it so difficult for patients to get the proper care that they need, especially when they're in this sort of limbo in transitioning across care levels. And so my agenda today is that I also want to take a specific focus on talking about suicide for people who have substance use disorders. Because in the substance use arena, when we talk about suicide, it's something that so many people just don't feel like they're especially equipped to even talk about. Even clinicians have a hard time talking about this topic. And it's not because clinicians aren't good at their jobs. It's more so because when we went to grad school, this was not something that was trained on. Like, this is usually something that we take as an elective, and then we sort of just learn on the job. And in learning on the job how to be able to provide appropriate treatment for people who are suicidal, we unfortunately end up in this sort of hit or miss situation. And that's where we end up seeing a whole lot of folk who end up in and out of these systems of care. And it can be a very devastating thing on all sides, as I've said before, where people are just always sort of passing the buck to somebody else, hoping that someone else knows what to do next. And in presenting some of those issues today, what I also want to talk a little bit about, and this is usually something that I give like for each of these topics, like I give several hours of talk. I did my best to condense this conversation that I'm hoping to have with each of you. Um, the US Surgeon General's call to action. in terms of how do you try to formalize some of the best practices in terms of delivering proper suicide care, and especially trying to handle care transitions across levels of care? What are some of the best practices that we can just sort of have an overview on, especially when we're working in the fast-paced environments that we're in, right? How do we keep in mind that we want to make sure that we have something a bit more formalized? We have a formalized protocol that we can follow so that we don't feel like we're winging it all the time, and so that people could get the care that they need, and that we're also in compliance. Say, for example, if you're Joint Commission accredited, how do you make sure that you're following each of their recommendations as well? And then I wanted to also try to contextualize some of this in delivering a case vignette and give some clinical considerations. When you have someone who's suicidal and who also has a substance use disorder, when we're talking about making sure that that person gets the proper level of care, what are some of the things that we want to make sure that we're looking at? And we can have a discussion about that. So care transitions. So I wanted to start off with some facts with you about some of the things that we're looking at and why we just sort of see this as such a dire situation. Because just on a general note, suicide risk, and when I talk about suicide risk, I'm talking about the risk of death. The risk increases immediately in the days post-discharge from inpatient, and that risk is 200 to 300 times higher than you'd see with the general population. And a lot of times, what often happens is that when people receive 24/7 level care and they're always being checked on, they have someone who's dispensing their meds, and they always have support from a peer counselor or a milieu counselor, or they're going to groups. That support is readily available from people who are trained in the field. They understand suicidal ideation, they can counsel you, but then post-discharge, that just drops. And a lot of times that could be a point of nervousness for some patients. And even though care on the inpatient floor can be very restrictive, at the same time, when they're receiving the care that they need from each of these counselors, it's people who understand the suicidal experience compared to the outside world, where you may have appointments arranged, but it's not on that 24-hour level that you get when you're inpatient. And another statistic that I found especially alarming is that 43% of suicide deaths, they occur within 1 month post-discharge from an inpatient unit. And 50% of those deaths, they happen even before the person gets to see their outpatient provider. And the Joint Commission reports that hospitals often face almost $2 billion in malpractice costs over a 5-year period because of not doing the things that they should be doing. And in fact, just before this presentation, I noticed that there was a survey from the Joint Commission that had come out from the Joint Commission Journal on Quality and Patient Safety that had noticed that of the 4 best practices that Joint Commission recommends, only 8% of them are doing those best practices, that they're adhering to each of the best practice recommendations from the Joint Commission, which would include formal safety planning, providing warm handoffs to the next level of care, following up with patients post-discharge, and providing lethal means safety planning and counseling. Only 8% of hospitals are doing that. And also, when we're looking at patients who are getting discharged from inpatient to the next level of care, there are 2 really big risk factors that people are privy to. And it can often even lead to overdoses. In fact, during the pandemic, the overdose rate went especially high because of a lot of the isolation that so many of us experienced during the pandemic. And poor engagement and people feeling isolated, those are 2 major risk factors that could lead to a death, including by overdose. And the fact that Joint Commission noticed that there is a largely informal, unstandardized care transition process, and not just with hospitals, but across systems of care, that in and of itself leads to a lot of the winging things that so many organizations can be prone to, and something that I'm hoping that as I work with people, can we talk more about how we formalize some of the best practices and make it more practical for each of the settings that are involved in, even if you're a place with limited resources. Trying to go to the next slide here. Okay. And so more on the Surgeon General's call to action, right? What do we do about trying to help implement a proper care transition protocol when you're either like in a inpatient setting, sending someone to the next level of care, or even you're like an outpatient provider and you're receiving that patient who needs care? So a lot of this stems on call to action number 5, and this is from the National Action Alliance for Suicide Prevention, which has various partnerships with, say, the Zero Suicide Institute, that even offers some proprietary systems and methods to implementing a zero suicide friendly environment you can work in and make sure that your patients are receiving the optimal level of care, among other places that they've partnered with. And the specific call to action that will be the focus for today is going to be call of action 5.4, which talks about ensuring safe care transitions, specifically when it comes to enhancing crisis care for people who are just coming into an outpatient level. And some of the best practices, they often, each of the 4 that I had brought up when it comes to providing formal safety planning, warm handoffs, following up with patients post-discharge, and lethal means safety planning, they fall into 3 different categories. As I said before, formalizing the process, which does include the safety planning and the lethal means counseling. And probably one of the most difficult things to do is making sure that providers have availability, right? For now, they're hoping that people can be able to schedule it within 7 days maximum post-discharge. It used to be 14 days. That got amped up when we saw during the pandemic that the demand was so high and that the care was largely unavailable because of the short staffing. They wanted to try to amp that up and also provide more funding for places to be able to hire more providers. And that, as you can see, is still in process for so many places. And then following up with the client is also of utmost importance, where we want to make sure that people are following up with patients about 24 to 72 hours post-discharge. And especially if you have existing clients who might have been readmitted inpatient, following up with them specifically when they've been discharged from inpatient level of care is especially important, so that they know that they are being followed, especially in their dire moment of need. And so if you could be able to book an appointment with them when they get discharged is especially important. And there are some other recommendations. I'm not going to go one by one in many ways. These are things that you probably already know, but the other piece of it in terms of following up is communication. Communicating with the provider, especially because when it comes to electronic medical records, EMRs, trying to make sure that all the records are reconciled, such as meds that they're taking and things like that. If you're working across 2 different systems and information sharing is something that's not as well adopted, that can be a really big challenge. So having that communication is especially key. And so now I'm going to jump into a case vignette of what would it look like if we're going to implement a lot of these best practices that I'm talking about. So this was actually based on a patient that I had treated. And of course, some of the things had been changed, but this is something that I think could really help us get a better understanding, like what would it look like if we were going to implement these things. So for example, a 21-year-old male, we'll call him Sam. someone who lived with his parents, was diagnosed with borderline personality disorder, and also suffered from severe cannabis dependence and had withdrawal symptoms. This patient also was recently diagnosed with emphysema due to chronic smoking. And this is someone who had, for a number of years, had suffered from chronic passive suicidal ideation. And one of the reasons that Sam had been referred to my care was that there was an aborted suicide attempt of jumping off a bridge and wanted to drown into the river. But he was stopped before he could do that attempt. Past attempts throughout his teens had been overdosing on medications, but not to a lethal degree, and having cut his wrists, had not told anyone, had not been hospitalized, but had told providers after the fact that this was something that he had done. And the ways that he would cope with his feelings, he would isolate in his room, and he would also smoke marijuana all day, every day, was even up all night, but slept for much of the day. And also presented with low self-esteem, and some of the negative self-talk he would give to himself was that he felt like he was a deadbeat son and that his parents were right, that he was not going to amount to anything, that he was not able to pull himself up by his bootstraps. No matter what anyone told him, he couldn't do anything right. And as you could imagine, this would lead to a lot of crying spells in the middle of the night that would keep him up. And so a bit more about Sam's psychosocial background. He was someone that he was going to college, but right before he attempted, he had decompensated in various ways. He dropped out of college. He quit his job as a retail worker. And Sam had an on and off girlfriend, but had broke up with this girlfriend right before the attempt that led to the hospital, the aborted attempt. And this girlfriend was also living with her own parents. And from time to time, whenever Sam had an argument with his parents, he would stay over his girl in his parents' house. And there was a lot of tension going on with Sam and his parents. One of them in that he felt like his mother was very performative with any sort of compassion or affection that she would give. And so that would lead Sam to not feel very comfortable in speaking with his mom. The other piece was that he felt like his father was especially hard on him. And his father would often repeat to him, "Oh, when I was your age, I had a job and I was able to work full time. I was able to live on my own. Why are you still living with me?" And that was something that Sam had a hard time listening to, but at the same time conceded that he felt like what his father said was true. However, in the days before Sam had decompensated to the attempt, extended family had come over and visited for a party. And what they had noticed was that Sam was, in fact, isolating a lot. And when one of the relatives checked on Sam, Sam had confessed to wanting to kill himself. And that family member wasn't quite sure what to do about it. And they had even gone to the parents and said, "Hey, did you know that Sam wanted to kill himself?" And parents will said, "Yes, but still, he needs to find a way to get over it and just get himself going." To which the extended family members were thinking to themselves, like, "Okay, he really needs help. Why are you not getting him the help?" And the thing was that supposedly he had received help as a teen, but Sam ended up dropping out prematurely because he didn't find therapy helpful. He found that people were making decisions without his consent, and he felt like he was forced to participate in the therapeutic process. However, what would also happen was that whenever Sam would even try to quit smoking marijuana, Sam would end up going through withdrawal symptoms after, say, up to a week. And then when they noticed that Sam, when he would withdraw, he would get especially anxious and especially dysregulated. they would go and buy him the marijuana to say, okay, I know this is bad for you, but at least it calms you down. We want you to feel better. And so there was some unhealthy ways of helping Sam through his illnesses. And some of the reasons for the outpatient referral of working with me, Sam had actually just come out of inpatient for the very first time with these co-occurring disorders of borderline and cannabis dependence. And what ended up happening specifically was that they had an argument in which the parents had ultimately said to Sam, like, oh, if you don't want to live here so bad, why don't you just get out the house? To which Sam said something to the effect of, oh, if you want me out so bad, okay, I'll leave. In fact, I'm going to go and jump off the bridge. And when Sam left, the parents then got concerned and chased him up to the bridge. On the way to the bridge, 911 was called. And the parents and the dispatchers managed to talk him out of jumping and got him over to the emergency room to be evaluated, and he was committed to inpatient. And so while Sam was going inpatient, Sam learned a lot about coping skills and communication strategies. And when Sam was on the floor and noticed when parents were getting involved in doing some of the family therapy components of treatment, Sam sort of felt like, okay, these coping skills would help if it was just for me, but because I'm living with my parents and I'm having a tough time learning how to communicate with them, using things like I statements, he would shut down. And he didn't feel like his parents would hear him out, and he would just sort of completely disengage from the conversation. So he didn't find those tools realistic to implement in the heat of the moment. And so that was something that Sam had struggled with. And furthermore, he also had those same marijuana withdrawals while inpatient, and he was attending some of the anonymous groups while inpatient. And he acknowledged that he had a problem with weed. He knew that he had a hard time stopping. Just the problem was that he had a hard time with the 12-step concept of, for example, the second step says you need to believe in a higher power, to which Sam sort of felt like, oh, if this is a requirement into participating in like a self-help support group program, he wasn't quite sure that that was right for him. And so, given all of these things about Sam, there are a couple of things to consider. Sam, for one thing, he's very impulsive, right? So, considering the fact that he just dropped out of college without any thought into the fact that his parents were paying for those classes and those kinds of things, he just couldn't see himself studying in school if he felt as miserable as he did. He just didn't see it happening. And Sam also engages in a lot of avoidant behavior. Excuse me. And so, him isolating in his room, one of the things that he'll even do is that, for example, when coming out of inpatient, one of the things that he was advised, him and his parents were advised, was, okay, how about you check on Sam when he's isolating in his room? You don't just leave him sitting there and hoping that he'll wake up. And so the parents would go in and check on him, see how he was doing. But what Sam would do was that he wouldn't respond. And then they try to rub on his shoulder again, like, hey, Sam, how you doing? Sam, what's going on? At a point to which Sam would just get up and walk away and not be near his parents, where he just felt like, oh, I just want to be left alone. I don't want to talk to you. I have nothing to say to you. This all feels fake. And so, because of all of that, there is a risk with Sam of disengaging in treatment. And so, making sure that Sam has someone that he can reach out to on a more consistent basis is very important. But also, him seeing that as you jump to the end of this, that he just feels like there's someone who actually does have his best interests at heart. He's also someone, though, that even if we have his best interests at heart, he doesn't like rigid treatment. But the other oxymoron to that is that he also doesn't really seem to trust himself. He has such a negative self-concept. And so when you take all that into consideration, this is something that we want to find something possibly that is going to be a flexible approach, but also could help him build a sense of confidence within himself. And Sam, all 21 years old, right? And so when we look back at these best practices where we want to try to formalize the care transition process, for example, like making sure that we have someone who is able to engage in formal safety planning, lethal means counseling, that the records, for example, when we talk about communicating with providers, that their records are reconciled and that their meds are also reconciled, that there is a sort of protocol when it comes to following up, like who is doing what kind of follow-up with the patient, because you don't want to duplicate efforts, but you also want to make sure that people are having some sort of contact so that this patient can continue to engage in care. And that can look like a number of ways. And when we're following up with the client for discharge, if someone is just coming into your care, one of the things you even want to know, like with the hospitals, are they checking in for safety? Have they had their meds? Are all of those meds listed in their record? Do they have follow-up appointments? Have they been reminded of their follow-up appointments so that we know that there has been effort made before they even came to outpatient level? Are they getting the care that they need? Right? And so for now, one of the things that I also wanted to just talk about is like when we think about the kind of care that Sam needs, there were a couple of things that we were looking at when we were engaging with him, right? And this was something that really required a comprehensive effort, because with Sam, he was someone where we were noticing a few things. He was highly dysregulated, but even though he really wanted the help, he was someone that he was also in many ways ambivalent about the system, given his systems, his experiences working within the system, right? He was someone where he felt like people really weren't listening to him. He didn't feel heard. And so he just felt like decisions were being made on his behalf. And so what ended up happening was that we ended up having an appointment booked with him when he was discharged from care. We had him booked with me within 7 days, but we also had a transition plan in place where with Sam, we were able to also have someone who was able to work with him on a very sort of short-term, in the agency, we called it an integrated care basis. We had someone who was able to set up peer-based counseling for him, where a peer-based worker could check in on him, see how he was doing, while also waiting to be seen for me in order to do the full on admission process. And we also made sure that in terms of safety planning, that when it came to his meds, that we had those meds up in a lockbox, for example, and that only his parents had access to the key. And that when it came to communications, that his parents had access to the lockbox key because he wasn't interested in having a visiting nurse come in. but that he was aware of what the dosage was and that his parents would be able to dole out his medicines whenever he was due for his next dose. So then that way, he was able to take the meds himself, but because he had a history of overdosing on meds, we wanted to make sure that there was someone who was able to at least just have the key to lockbox, but he was able to take the dose in supervision. And so those were some of the things that we had looked at. And that we also wanted to make sure that Sam was also able to stay connected, because he was able to get back with his girlfriend. And in speaking with the girlfriend, she was someone who was a very big support system to him. And so making sure that she also checked in with him as well. Those were all things that we incorporated as part of his safety planning, and also just making sure that he also knew about 988. Because if he did not have somebody readily available, say in the middle of the night when he was having one of those episodes where he just felt like he was all alone and decompensating, does he have anyone that he could talk to? Let's say if his girlfriend wasn't available, at least having someone where he could talk about what was on his mind while he sort of needed to get things off his chest. He needed to feel heard at the same time, not feel like, okay, he needed to be, rushed to the hospital, because he felt like, okay, I'm not going to go and try to jump off the bridge again, but I'm still feeling very strong. And I'm not sure how to navigate these feelings, especially if the therapist is not available in the middle of the night. And so at this point, there's more that I can get into, but I wanted to sort of open this up to questions for now. I'm going to stop sharing my screen. Does anybody have questions about anything? Does anybody even have comments, and even any other considerations about this particular case vignette? I'm just checking here if anyone has their hand raised or if anyone wants to type into the chat. No one has anything? Nobody? All right. Well, at this point, this actually concludes the presentation. So, oh, I appreciate that. Thank you. So this actually concludes the presentation, unless anybody wants to stay on and has any additional questions, any other considerations about what it might look like to make sure that people have the proper transition care process in place. Feel free to stay on, but that's it for today.
Thank you so much, Yvette. This has been I appreciate you sharing your knowledge with us and taking your time.
Of course.
Thank you, everybody.